Hi, my name is Ron Blankstein. I'm an Associate Professor of Medicine and Radiology at Harvard Medical School, the Director of the Cardiac CT Program, and the Associate Director of the Cardiovascular Imaging Program. It's my pleasure to talk today about lifestyle recommendations for prevention. This is certainly one of my favorite topics. I do not have any relevant disclosures. For today's talk, I'm going to talk about different types of prevention. I'll review the AHA's LifeSimple 7. We'll review some data on diet and how it influences cardiovascular disease. We'll review some of the ACC-AHA guideline recommendations as they pertain to lifestyle changes. We'll briefly touch on the U.S. dietary guidelines. We'll answer the question whether lifestyle changes can prevent diabetes, and we will conclude with a discussion regarding how much exercise we should recommend to our patients. So whenever I talk about prevention, one of the first things that I like to remind my audience, both clinicians and my own patients, is that coronary heart disease is mostly preventable. I'm always surprised that some people find this shocking, but the reality is that most coronary heart disease events that we see as cardiologists can be prevented. When we talk about prevention, there are different types of prevention, which are shown on this slide. Primordial prevention is prevention of a coronary heart disease risk factors. Primary prevention, modification of risk factors in order to prevent or delay the onset of coronary heart disease. And secondary prevention is the initiation of therapy to reduce recurrent CHD events and decrease cardiac mortality in patients that already have established coronary heart disease. I have to say that in today's era, the delineation between primary prevention and secondary prevention is not always clear. We often diagnose coronary heart disease in early stages with imaging tests such as a calcium score or perhaps even just an invasive angiography. And a question that I think remains unanswered is when we see coronary artery disease in a patient who has not yet had an event and we now treat them, do they qualify as primary prevention or secondary prevention? Perhaps it doesn't matter as long as we recognize their risk and that we're treating them aggressively, but I think it is relevant at least to delineate that the border between primary and secondary prevention in today's era is less clear. So when we talk about prevention, I do think it is helpful to review this document that was put forth by the AHA, which was meant to implement new goals for reducing cardiovascular events. So specifically, this new concept of cardiovascular health was defined by the AHA was a goal by 2020 to improve the cardiovascular health of all Americans by 20% while reducing death from cardiovascular disease and stroke by 20%. And in this document, one of the important concepts that is now being defined, and hopefully in a simplistic approach that we can all follow, is the definition of ideal cardiovascular health. To define this, there are 7 variables that you can see on this slide. And those include smoking, maintaining a low BMI, remaining physically active, having a healthy diet, which is based on 4 to 5 components, which range from consumption of fruits and vegetables, fish, whole grains, low sodium diet, and low consumption of sugar-sweetened beverages. In addition to that, attaining a low cholesterol, low blood pressure, and a low fasting glucose. And there's data from now several studies showing that the more healthy we are, so the higher the cardiovascular health metric, the lower the event rate, and specifically we have seen that with a higher score, there is a lower mortality, lower all-cause death, less coronary plaque, less atrial fibrillation, and less stroke. So certainly a lot of benefit from achieving optimal health as defined by the AHA. But how do we do? If we look at population data, it turns out that if you look at these 7 metrics, and this slide here, you can see in red the proportion of individuals that attain poor control. You can see that we have poor control of many of these risk factors in our population. And the most relevant or the most significant one here is a healthy diet score, where over 3/4 of the population seems to have poor control of this specific risk factor. So with that in mind, I would like to review dietary recommendations and try to at least identify what diet is best for our patients, with the recognition that there's not always going to be agreement by everyone on every aspect of diet. And in fact, this is a pretty challenging area to study. This is an editorial from the New York Times from 2016, which is titled, "We're So Confused, the Problems with Food and Exercise Study." And this editorial appropriately points out that there's often no gold standard of measuring the effects of our interventions or the interventions themselves, and there's nothing that everyone agrees on and uses to measure aspects of lifestyle. In fact, the editorial states that the problem with lifestyle studies are so overwhelming that it might be best to just give up on all those questions altogether. Well, that's certainly a pretty pessimistic view, and I hope none of us will give up on these important questions, but at least this shows us how challenging it is to make sense of some of the data in this field. In 2010, there was this particular publication that came out in JACC that looked at diets and cardiovascular disease. And I think that there's some important take-home points from this review. First of all, right around 2010, we have realized that for years the AHA recommended a low-fat diet, and in fact there was almost an obsession in our country with low-fat diet. And this had the unintended consequences of promoting unrestricted carbohydrate intake, often sugar, often refined starches such as bread, pasta, cereal. On the flip side, there's now been almost a resurgence at times of very low carbohydrate diets, ranging from the Atkins diet to more recently some of the ketogenic diets. And while those may be successful in the short term at weight loss, they do have other adverse effects on coronary heart disease risk factors. And specifically, they may be atherogenic because many of these diets can be high in saturated fat and cholesterol. So low-carb diet may not always be the answer, and certainly is not the answer to the high carbohydrate intake that we have seen in our country. And I think one of the important aspects that's often not seen in most studies is the type of carbohydrates. Not all carbohydrates are the same, and when we talk about whole grains as opposed to refined carbohydrates, those probably have very different effects on our body. But if we go back to the theme of why carbohydrates, specifically refined carbohydrates, are bad for you, the number one culprit here is sugar, and this is a wonderful cartoon put together by CardioSmart, which actually presents an amazing statistic, and that is that on average, Americans consume 6 cups of sugar a week. That's kind of hard to imagine, 6 cups of sugar a week. And where is this sugar coming from? At least half of it seems to come from sugary drinks. And sugar, of course, comes in many different forms. And I think it's important for us to educate our patients when they look at labels that it's not just sugar, but many other names ranging from agave syrup to cane syrup, high fructose corn syrup, honey, galactose, rice syrup. All of these essentially are different forms of sugar that metabolically act in an identical manner. It may come to no surprise to many from data from this recent review article in JACC that when we look at epidemiological study, such as in this meta-analysis, individuals that consume a high amount of sugar-sweetened beverages, SSB, have a higher mortality, so higher mortality. On the flip side, if we look at beverages in this meta-analysis, maybe good news for coffee drinkers, lower mortality here for coffee as well as for green tea. Of course, there's always studies pointing in many different directions when it comes to this, but I think one thing we can agree on from this slide is that sugar-sweetened beverages a higher cardiovascular disease rate. What about the impact of diet at lowering cholesterol? This is certainly a common question, and many of us will have patients ask us in the clinic, is there anything we can do to lower our cholesterol short of a statin medication? And the answer actually may be yes. And this is based on the Portfolio diet, first published in JAMA in 2003. And in this particular diet, or this particular study, 46 healthy hyperlipidemic individuals were randomized to one of 3 interventions, either a low-fat diet, a low dose of a statin, specifically lovastatin 20 milligrams a day, or the dietary Portfolio diet, which included plant sterols, soy protein, viscous fiber, and almonds. And as you can see in this slide here, over the 4-week study period, there was a significant reduction in LDL cholesterol and CRP, which was equivalent in patients who received the low-dose statin or the dietary Portfolio. So this is an important study, at least showing us that we can achieve effects that are similar to a low-dose statin with diet. However, this is only 4 weeks. What about longer horizons? In this particular follow-up study now looked at 6 months, showing that for both a routine dietary Portfolio or more intensive dietary Portfolio, there was a significant reduction again in LDL cholesterol, which has been now attained for 6 months. So at least we have data that this may last for a while. Well, we can lower LDL cholesterol with diet, but can we actually prevent cardiovascular events? What if we have patients who come and see us in the clinic and they already had a myocardial infarction? Is there any data that we can reduce their risk of future cardiovascular events? The answer is yes, and this is based on the Lyon Diet Heart Study, which now took 605 patients who experienced a myocardial infarction and randomized them either to a Mediterranean diet or a Western diet for 4 years. Specifically, the Mediterranean diet, which we will discuss further, is high in polyunsaturated fats and fiber, as opposed to the Western diet in the green curve, which is high in saturated fat and low in fiber. And what you can see here is that during this study period, which randomized 605 individuals, there was a significant reduction in cardiac death or myocardial infarction among patients who were randomized to the Mediterranean diet as opposed to the Western diet. So certainly good news for the Mediterranean diet here, but perhaps one of the limitations that has been pointed out is if you look at patients randomized to the Mediterranean diet, there's still a significant event rate. Can we do better? Can we get this red curve to be even flatter so there's fewer events for our patients? Well, before we can answer that question, the next step with regard to the Mediterranean diet to see whether these results extend for primary prevention. So primary prevention, and this is the largest study ever done with diet and primary prevention, which is the PREDIMED study, which now attempted to look at the potential benefits of the Mediterranean diet in patients that did not have any cardiovascular disease at baseline. And in this particular study, individuals were randomized to 3 arms. So there was a low-fat control diet, and then there was a Mediterranean diet. And furthermore, patients who were randomized to be on the Mediterranean diet were randomized to either to receive their fats from extra virgin olive oil or from nuts, mostly almonds here and walnuts. And as a result, the fat consumption in the Mediterranean diet patients was high, but it was lower in saturated fat than the typical Western diet and higher in monounsaturated and polyunsaturated fats, but still a high fat diet, but different types of fat. And the result was, over the follow-up period, that there was a 30% relative risk reduction in the primary endpoint. However, in the primary endpoint as shown here, acute MI, stroke, or death from cardiovascular causes, However, this was driven mostly by a reduction in stroke. So it seems that the Mediterranean diet may be especially advantageous for reducing stroke when compared to a controlled diet, which is high in saturated fat and low in fiber. Well, again, some folks that would criticize this study would say that even in the Mediterranean diet, there was still a substantial event rate, and the question is, can we do better and reduce this? And one potential diet that has shown a lot of recent advantage is a whole food plant-based diet. The literature in this area is certainly smaller than the Mediterranean diet, but still very compelling. There's different types of plant-based diet. Dr. Caldwell Esselstyn has been an advocate for a whole food plant-based diet with no added oils. And you can see here his book, and he certainly has a very significant experience from the Cleveland Clinic, where he has shown in his own patients a dramatic reduction in the amount of coronary artery disease in a large subgroup of his patients. The plant-based diet has also been advocated by this book, The China Study by Colin Campbell and others. A website that I think is helpful for many of you who want to learn more about this is nutritionfacts.org, that also talks about various beneficial aspects of a plant-based diet. When we look at the literature and we try to understand, is there actually an advantage for a plant-based diet? One of the more important publications is this one from 2016 from JAMA Internal Medicine. And in this large retrospective study, they looked at the impact of substituting various animal sources of protein with plant-based protein, and the impact specifically on all-cause mortality, cardiovascular disease mortality, and cancer. And what we can see in this specific figure is as you replace protein with plant-based protein, there's a significant reduction in these endpoints, especially for replacing processed red meat, where these lines are furthest to the left. But when we look at all-cause mortality and cardiovascular mortality, there is also a significant advantage here when we replace unprocessed red meat, poultry, fish, eggs and dairy with plant-based protein. For cardiovascular disease mortality, very similar endpoint. For cancer, it seems that actually eggs may be a culprit here, and replacement of eggs with plant-based protein is beneficial for reducing the incidence of cancer. So important study which supports the plant-based diet. Another study, even though it's old, but I think relevant to include for this particular discussion, is the Ornish diet. So Dean Ornish performed this study on 48 patients that had moderate to severe coronary heart disease who were randomized to an intensive lifestyle group versus usual care group. And what he showed in these patients who were followed for up to 5 years is that compared to the usual care group, his particular intervention, which was a low-fat diet, less than 10% of the calories were from fat. This was mostly a vegetarian diet, which was also combined with exercise and stress reduction. But in these patients, there was a 90% reduction in the frequency of angina after 1 year and 72% reduction in angina after 5 years. So very significant reduction in angina. And also interesting is the fact that when they looked at invasive angiogram in these patients, there was a significant decrease in diameter stenosis in patients that were on this particular diet intervention. Possibly the impact here is by reducing LDL cholesterol, because these patients had far fewer saturated fats and far less cholesterol consumption. The other possible effect here is that both the dietary interventions and exercise can improve microvascular function, and as the microvascular health improves, there may be a better flow down the larger epicardial vessels. So certainly interesting results in this warrants further larger studies, especially comparing this diet or other aspects of the plant-based diet was the Mediterranean diet. But the fact that epicardial stenosis improved should be of no surprise. Many individuals are often surprised at the fact that maybe diet can actually reverse coronary heart disease. And just an example from one of my own patients, on a patient that was treated aggressively with medical therapy and lifestyle changes. And in this specific coronary CTA, we see a large amount of mostly non-calcified plaque in the left circumflex before the implementation of aggressive therapies, and where afterwards we see only minimal stenosis in the left circumflex. So certainly epicardial coronary artery disease and microvascular disease can be improved with the combination of lifestyle therapies and medical therapy. Let's next turn to the guidelines and learn a little bit more what the guidelines have to say with respect to diet, exercise, blood pressure lowering, and other parameters that are relevant for our patients. The first guideline that I wanted to review is the recently released 2017 guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. So these are the hypertension guidelines. And I think a very important part of these guidelines is the fact that they recommend lifestyle interventions that we should advocate for all our patients, and we can do this for all patients, and we can do this before we even implement medical therapy. And in fact, there are 6 recommendations here. All of them have a Class 1A level of evidence. So this is a very, these are recommendations, and they're certainly evidence-driven. And the recommendations are to focus on weight loss for lowering blood pressure, a heart-healthy diet, such as the DASH diet, which we will review in the next few slides, sodium reduction, potassium supplementation, and this preferably should be via dietary modifications, and certainly one way to increase potassium in the diet is through a higher consumption of fruits and vegetables. Increase in physical activity with a structured exercise program, and we will talk more about that also in our talk today. And finally, decrease alcohol consumption. In this document states no more than 2 for men and 1 standard drinks per day for women. So these are all very important recommendations and ones that we should provide all our patients. But when we look at all this, the question is, well, of all these effects, which are actually most important? And certainly they're all important to implement. Weight loss seems to be a core recommendation, and there is a direct dose response between how much weight individuals lose and how much the blood pressure improves. Specifically, we can expect 1 millimeter per mercury of blood pressure reduction for every kilogram of weight loss. So the more weight loss, the better when it comes to this. This particular table, also from the guidelines, show us the anticipated impact on systolic blood pressure for both individuals with high blood pressure and those who are normotensive. And when we compare these different measures that we just talked about, it seems that healthy diet has the greatest reduction in blood pressure. Of course, you would achieve more with weight loss if there was substantial weight loss. But when we compared the relative impact of these interventions, healthy diet, which is defined as one that is high in fruits, vegetables, whole grains, low-fat dairy, with reduced content of saturated and total fat, a diet similar to the DASH diet pattern, or similar to the plant-based diet, the only difference there being the low-fat dairy. But with these diets, we would anticipate a significant reduction in systolic blood pressure. Well, the strongest evidence really does come from the DASH dietary pattern. And this is a slide from the DASH diet, first published in the New England Journal of Medicine in 1997. And in this particular study, 459 hypertensive patients were randomized to one of 3 diets. A diet in green, which is low in fruits and vegetables and dairy products. That one had the least reduction. A diet that was enriched in fruit, vegetables, and fiber, in a diet enriched in fruits and vegetables and low in fat and cholesterol. And you can see here that the diet that were higher in fruits and vegetables did better, but the one that was low in fat and cholesterol did even better with respect to reduction of both systolic and diastolic blood pressure. Importantly, if we actually look at these interventions, one important point is that the sodium content was the same in all of these three diets. It didn't change much. And in these diets, a potential mechanism for the reduction in blood pressure was the fact that the diets that are high in fruits and vegetables are also high in potassium, magnesium, and calcium. In fact, these diets were kind of designed to have a 75th percentile consumption level for these nutrients. So again, sodium was the same in all these, so independent of sodium, more fruits and vegetables, in low fat and cholesterol will reduce blood pressure. But what if we on top of that now also lower sodium? So this is the DASH sodium results, where we now look at systolic blood pressure on the top, diastolic blood pressure on the bottom. And what we can see is as the level of sodium goes from high to intermediate to low, systolic blood pressure, both for the controlled diet, goes down, and for the DASH diet goes down. So significant reductions in blood pressure as we reduce the amount of sodium going from left to right. Perhaps less so, but still a significant result for diastolic blood pressure for the controlled diet, and for going from an intermediate to a low level of salt for the DASH diet. Again, a more attenuated response for diastolic blood pressure. But the bottom line here is that the lower the sodium, the better individuals do. And based on this study, the recommendation for the amount of sodium is less than 2.5 grams per day, or more recently in many documents, 2,400 milligrams of sodium. So to review how these recommendations, or how this study has influenced recommendations, here are the 2013 AHA-ACC guidelines on lifestyle management. And the advice given here to adults who would benefit from blood pressure lowering is to consume no more than 2,400 milligrams of sodium. Further reduction to levels of 1,500 milligrams or below may provide even greater reduction. Certainly this can be more difficult for individuals to follow, but maybe even more of a reduction here. Even without achieving these goals, individuals who have a high sodium consumption may reduce their blood pressure by lowering the relative sodium consumption and lowering it by at least 1,000 milligrams per day. And these recommendations here are additive on top of a DASH dietary pattern, which is, again, a pattern that's high in fruits and vegetables, whole grains, and fiber. So specifically combining DASH and a low-salt diet seems to be effective. I think it is important to know that salt sensitivity varies in our population. Individuals with refractory hypertension may be more sensitive to salt, as are elderly individuals, as is African Americans. So these are all groups that may have more to benefit from reducing the amount of salt in their diet. But I think it's always important to put all these recommendations in context. At times we may see an elderly individual who has orthostatic hypotension, and in them asking them to reduce their salt consumption to these very low levels may actually be harmful. So we always have to put this in the context of the patient that we are treating. And the guidelines certainly recognize this. In fact, the guidelines do appropriately state that nothing in these guidelines is a replacement for clinical judgment. The ultimate decision about care of a particular patient must be made by the provider and patients, and certainly situations arise where deviations from these guidelines may be appropriate. Well, I guess we probably will see statements like this in many guidelines. This is why they're just guidelines at the end of the day. Okay, so we talked about blood pressure lowering. What about LDL cholesterol lowering? What would the guidelines tell us to do there? And if we look at the the guidelines, the advice to adults who would benefit from LDL cholesterol lowering is to consume a dietary pattern very similar to blood pressure lowering pattern, which emphasizes the intake of vegetables, fruits, whole grains, low-fat dairy products, poultry, fish, legumes, non-tropical vegetable oils. So again, these are not non-tropical, because tropical are things like coconut oil, which are high in saturated fat, which would not be advised, high in nuts, and of course limit the intake of sweet, sugar-sweetened beverages and red meats. So these would all be beneficial attributes for lowering LDL cholesterol. Advocates of the plant-based diet would say that even poultry and fish can actually be quite high in cholesterol and may raise LDL cholesterol. So perhaps for those who want to perfect these recommendations, leaving out the poultry and fish may have some added value, but certainly we need more studies in this perspective. And when we look at this recommendation, the aim for a dietary pattern for patients who seek to lower their LDL cholesterol is to achieve 5 to 6% of calories from saturated fat. Today in the US, for many people, this number ranges between 10 to 20%. So lowering the amount of saturated fats is very important if we want to lower LDL cholesterol. I want to quickly review the U.S. dietary guideline recommendations. These are really not one that we follow as clinicians for the most part, but many patients may view these guidelines. There's been a lot of criticism of these guidelines, that they may be influenced by lobbyists, may be influenced by industry, and as a result, these guidelines in a way suggest that everything in moderation may be okay, which is really not the message that many of us would give our patients that have coronary heart disease. So specifically, these guidelines fall short on recommendations such as avoiding refined grains, starches, red meats, or processed meats. They say, well, you can have a little bit of everything, which really may not be the best advice for our patients. So just a point that I think is worthwhile mentioning with respect to these guidelines. Let's now talk about lifestyle changes in the topic of whether these can prevent diabetes. This is particularly important in light of the obesity epidemic that we are noticing in the US, which has been associated with a rise in the incidence of diabetes. Well, many of you may be familiar with this old study all the way back from 2002, the Diabetes Prevention Program. In this particular study showed that compared to placebo, it turns out that lifestyle changes were more powerful at preventing diabetes than medication such as metformin. In fact, if you look at the numbers here, one case of diabetes was prevented for every 7 persons treated with lifestyle changes for 3 years, and for every 14 people treated with metformin. So lifestyle changes seems to be twice as powerful as taking a medication for preventing diabetes in this particular study. And the lifestyle modifications here included a 7% weight loss and 150 minutes of activity per week. And very significant reduction in diabetes, over 50% in this particular study. So these results, however, generated a lot of important data about how lifestyle can prevent diabetes. However, less promising results were seen several decades later in the Look Ahead study. So in the Look Ahead study, 5,145 overweight patients with diabetes were now randomized to intensive lifestyle intervention or control group. The lifestyle interventions here included 7% weight loss via eating less calories, as well as exercising 175 minutes per week. And what we can see here is that there was a significant reduction in weight and waist circumference, and more so in the intervention group, but we can see that it did not sustain over the prolonged time period of the study when we look out to 10 years here. So there's a dip, and then there's a kind of a rise back up, and we can see this both for weight loss and waist circumference. We can see A1C went dramatically down, but then trended back up. But importantly, when we look even at the control group, we can see that there is a reduction in weight in at least a mild reduction in weight loss. And this really gets to the fact that patients that participate in trials are more motivated to lose weight, so this may have minimized the differences between the groups, as did the fact that a lot of these interventions were not well sustained in the long term. And in fact, when we look at the endpoint in this particular trial here, we saw no difference between the control and the intervention group with respect to CV death, myocardial infarction, stroke, or hospitalization for angina. So perhaps medical therapy attenuated the effects of lifestyle changes in this particular study. The other criticism here is that dietary changes were not that strictly defined. Patients were just told to eat less calories and lose weight, but it did not focus on the actual dietary composition, and that may be much more successful because diet is far more complicated than how many calories people are consumed, but it really has to do with the nutrients. We know now that certain nutrients are more pro-inflammatory. We know that the nutrients that we eat affect our microbiome. There's emerging science on trimethylamine oxide, TMAO levels, that may be increased by certain diets. So a lot more we need to learn, and I think there's a role for much better studies in the future, in that we should not give up on lifestyle interventions in light of this apparently negative trial. Let's now talk about how much should we exercise, or how much exercise should we be prescribing to our patients? Well, this slide shows the recommendations from the American Heart Association. I always like to emphasize to people that this is the minimum amount of exercise that we should be recommending, and that is at least 30 minutes of exercise at least 5 days a week, so that totals 150 minutes per week. Not that much, but still most people don't achieve this. Or if we look at, and this was for moderate intensity aerobic exercise, if we talk about vigorous aerobic activity, an optional recommendation here is to do less but do more vigorous exercise, so 25 minutes for 3 days a week, so 75 minutes of vigorous exercise, or perhaps a combination of these two. In addition, these recommendations suggest that individuals participate in muscle strengthening activity at least 2 days a week. And the other recommendation here is that if the goal is to lower blood pressure and cholesterol, it may be beneficial to actually have more exercise or longer sessions. So instead of 30-minute or 25-minute sessions, the recommendation for lowering blood pressure and cholesterol is to have an average of 40 minutes of moderate to vigorous activity performed 3 or 4 days a week. So perhaps this is based on some data that longer duration sessions may be more beneficial. The AHA guidelines do state that if I can't make it to the time goal, something is always better than nothing, and that's certainly true that some exercise is always better than no exercise. But I do think it's important for us to strive to have our patients exercise as much as possible, as opposed to telling them to do less. So more is better than less. And in fact, a reminder again that this is the minimum level of exercise. If we look at some studies, such as this meta-analysis that included over 1 million participants, that what we can see is that compared to those who exercise for 150 minutes a week, individuals that actually exercise for 300 minutes a week, so this is now an average of an hour a day instead of half an hour a day on the days that you exercise, we see a more significant reduction here in the relative hazard of all-cause mortality. That was with respect to amount of exercise, but even if we look at cardiorespiratory fitness, as in this study from Feldman, Blaha, and colleagues, what we can see is that patients who have higher level of fitness, as judged by the amount of METs, seem to have a lower probability of death. This has now been shown by several studies that the higher your fitness level, the better individuals do with respect to mortality. I think it's also important these days to realize that physical activity can be defined in different ways. Physical activity can be structured physical activity or exercise, which is planned purposeful activity undertaking to promote health and fitness. This is the activity that we're generally recommending to our patients. But there's also incidental physical activity, which is not planned and is usually the result of our daily activities at work, at home, or during transport. And more, there has been recognition that both of these are important. It's not just about how much you exercise when you're performing purposeful activity, such as at the gym or going for a walk, but it also is important what we do during the day. And in fact, many of you have heard of this new saying here that sitting is now the new smoking because of all the adverse cardiometabolic activities of physical inactivity. In fact, in this slide here, we can see some of the proposed mechanisms whereby physical inactivity leads to more inflammation, dyslipidemia, higher rate of diabetes, hypertension, obesity, and all of these together can act for promoting, accelerating, or developing atherosclerosis. So in addition to recommending structured exercise for our patients, I do think it's important to also ask our patients, how active are you on a daily basis, and how much sitting, standing, and walking do you do? The goal here is to avoid sedentary behavior, whether it's sitting in front of the television or just sitting in the office all day. And one way to encourage this is to provide patients with a goal that's now been backed by several studies, which may be relevant for many patients, but not all, is to achieve 10,000 steps a day. Patients can now monitor this given watches or using pedometers. There's more and more technologies that individuals can use to track the number of steps they take. And interestingly, it's been shown that when patients are given a goal, they have a greater change in physical activity, meaning they take more steps compared to studies where no goal is given. So advocating a particular in a specific goal for our patients is very useful. Before we summarize, I just wanted to also add this slide that many of you can read later on. So this is, again, from the 2013 Lifestyle Guidelines. And this is a table that summarizes many of the recommendations in the guidelines and many of the recommendations that we discussed today that many of you can read on your own. So in conclusion, diet and exercise interventions, while difficult to study in trials, and I certainly did not get into all the challenges in trials here, they are certainly important in preventing many cardiovascular disease and non-cardiovascular diseases and are complementary to our preventive medical therapies. Additional research is needed comparing the various diets, such as the Mediterranean diet to a plant-based whole food diet, to determine which one is most beneficial. We have never had any studies comparing those head-to-head. Increased public health measures are needed to increase the availability of fruits and vegetables while avoiding sugar and processed foods. We talked about various diet, and while not everyone is going to agree on what is the best diet, and some people's viewpoints are based on what diet may be easier to implement on a public health level, but one of the things that we should all agree on is that all individuals should increase their consumption of fruits, vegetables, whole grains, in fiber, and all individuals should decrease and avoid the consumption of trans fats, decrease saturated fats to as much as possible, decrease or avoid sugar and refined grains. We're going to close with two questions. The first one is, which of the following is true regarding the dietary approach described? A, Mediterranean diet lowers the risk of CVA among high-risk patients without cardiovascular disease. B, the DASH diet has been shown to lower the risk of cardiovascular events. C, a whole food plant-based diet, when compared to the Mediterranean diet, improves insulin resistance. And D, the portfolio diet reduces LDL cholesterol similar to moderate intensity statin. The correct answer here is A. The Mediterranean diet in the PREDIMED study, in fact, lowered the composite endpoint of events, but this was driven by a significant reduction in stroke among patients that did not have known cardiovascular disease. The DASH diet has been shown to lower blood pressure, but has never been studied in a large outcomes trial or shown to lower the risk of actual cardiovascular events. Both the whole food plant-based diet and the Mediterranean diet have been shown in separate studies to improve insulin resistance, but the two have never been compared against each other. And finally, the portfolio diet does indeed reduce LDL cholesterol, but the comparison was similar to mild intensity statin, not a moderate intensity statin. Next question. Which of the following are limitations of studies assessing the role of diet in preventing cardiovascular disease? A, recall bias. B, publication bias. C, confounding by other lifestyle interventions or medications. Or D, all of the above. Correct answer here is all of the above. Indeed, all of these limitations have been present in many diet and lifestyle intervention studies, which does make the literature at times difficult to interpret. But at the end of the day, this calls for larger trials and more studies to be performed in this field.